Hi everyone. Today we will discuss about the topic etiology of malocclusion. A various classification has been proposed regarding etiology of malocclusion, which includes White and Gardiner classification, Salzman classification, Moyes classification, and Graeber classification. Coming to Graeber's classification, it may be of both general and local factors, and general factors are mainly hereditary, congenital, environmental, that can be both prenatal as well as postnatal, predisposing, metabolic, climatic, and infectious diseases, abnormal pressure, habits, and functional aberrations, including thumb sucking, tongue thrusting, and speech defects, and dietary problems, posture, trauma, and accidents. And local factors mainly involves anomalies in the number of teeth, tooth shapes, tooth size, abnormal labial frenum, premature loss of deciduous teeth, prolonged retention of deciduous teeth, delayed eruption, abnormal eruptive pathway, ankylosis, dental caries, and improper dental restorations. Now we move on to the general factors. First one is hereditary. It includes factors that result in malocclusion and are inherited from the parents by the offspring. These factors can influence the neuromuscular system of the baby, dentition, skeletal structures, and soft tissues. Neuromuscular system. If there is a deformity in the neuromuscular coordination pattern of facial, oral, and tongue musculature, it will result in malocclusion. And in dentition, hereditary will be shown as anomalies in size and shape of teeth, number of teeth, primary position of tooth germ, shedding of deciduous teeth, sequence of eruption, mineralization of teeth. Skeletal structures. In skeletal structures, the underlying basal bone and other associated cranial bone structures are partially inherited. One such example is class 3 skeletal pattern, most commonly show a familial tendency. And soft tissue inheritance may be seen in the form of size and shape anomalies of the frenum, microstomia, and ankylosing. The second factor in general category is congenital factors. Congenital factors, these are malocclusions which are seen at the time of birth, and it is due to the maldevelopment of first and second branchial arches. Common conditions are micrognathism, oligodontia, anodontia, cleft lip and palate, congenital syphilis, maternal rubella infections, credocranial diastosis, and cerebral palsy. Micrognathium, which is otherwise known as small jaw, it is a congenital variety usually seen along with congenital heart diseases and peri-Robin syndrome. Micrognathia of maxilla is often seen as a deficiency in the premaxilla, and mandibular retrognathism is characterized by a severe retrusion of the chin. Oligodontia, here different teeth seem to be affected by a different degree, with third molar being most affected. And anodontia, it is the absence of teeth and it is very rare condition. And cleft lip and palate, it is generally associated with the underdeveloped maxilla and related dental disturbances. These are the congenital factors in affecting malocclusion. Then congenital syphilis. Syphilis of congenital origin is transmitted from the infected mother to child, and the features are Hutchinson's molar, mulberry molar, enamel deficiency, extensive dental decay, small maxilla, and anterior crossbite. Another factor is maternal rubella infections. It may be shown as dental hypoplasia, retarded eruption of teeth, and extensive caries, which will lead to malocclusion at a later stage. Then another disease associated is cleidocranial diastosis. It is either unilateral, bilateral, partial, or complete absence of the clavicle. Maxillary retrusion and mandibular protrusion is often associated, and over-retained deciduous teeth and retarded eruption of permanent teeth is often seen, and it usually present with the presence of a multiple supernumerary teeth. Another congenital defect is cerebral palsy. It is aberrant muscle activity resulting in malocclusion. Coming to the third factors in general category, that is environmental. It can be both prenatal as well as postnatal factors. Prenatal factor is abnormal fetal posture. This interferes with the symmetric development of the face, and it's not directly associated with malocclusion, but may be associated with abnormal pressure or imbalance. And most of the deformities are temporary and disappears with time. Maternal infections such as German measles and use of certain drugs during pregnancy like thalidomide can cause congenital deformities like cleft. Postnatal factors include trauma, that may be a forceps delivery that can result in the injury of DMG area and which can undergo ankylosis, resulting retarded mandibular growth. This is an example. This is an ankylosis of the temporomandibular joint. Here, this is a 19-year-old patient having ankylosis of both TMJ. We can see the considerable inhibition of the development of mandible occurred as a result of early damage to the joint. And the patient is having an extreme case of mandibular retronatism, and we often call it Vogt Jesset. Another factor in general category is predisposing metabolic, climatic, and diseases. Metabolic conditions such as endocrine imbalance, that is hypothyroid, hypopituitarism, and again okay. Then we'll discuss about the predisposing metabolic, climatic, and diseases, which often cause malocclusion. Considering metabolic diseases, first we deal with the endocrine imbalances. Here the diseases may be hypopituitarism or hyperpituitarism. Hypopituitarism is shown as delayed tooth eruption or incomplete tooth formation. Hyperpituitarism is often seen as a very large mandible, enlarged tongue, and accelerated dental development. Then another condition is hypoparathyroidism and hyperparathyroidism. Hypoparathyroidism is seen as retarded eruption, early exfoliation, and enamel defects. These often lead to malocclusions. And hyperparathyroidism is seen as demineralization, disappearance of lamina dura, and mobility of teeth. Consider the metabolic disturbances. Acute febrile diseases also affect the dentition and its surrounding hard and soft tissue. And if the severity and duration is not prolonged, the child is able to recoup and catch up the growth is possible. Another factor is infectious diseases. It may be bacterial infections, osteomyelitis. In osteomyelitis, the bone response to force is altered. Another condition is congenital syphilis, which often result in underdeveloped maxilla, narrow maxillary arch, enamel hypoplasia, and defect in shape of teeth, which often lead to malocclusions. Then viral infections like mumps, measles, and rubella. Mumps often present as dental hypoplasia, retarded eruption, extensive caries, inflammation or congestion of gingiva. Measles often present as airway obstruction, which may lead to malocclusions by mouth breathing or something. Rubella, retarded eruption of teeth, congenital malformation, including cleft lip and palate, are often associated with it. Another condition is dietary problems. Dietary problems we can see mainly as protein deficiency, vitamin deficiency. Protein deficiency often lead to delayed eruption of teeth. And vitamin deficiencies such as vitamin A deficiency, here the calcification of teeth is affected and it causes retarded eruption. And vitamin B complex deficiency is mainly seen as a retarded growth and cheilosis and pernicious anemia. These all lead to malocclusion at a later stage. Then vitamin C deficiency, vitamin D deficiency. Vitamin C deficiency, here we have a disturbed collagen fiber formation and patient will present with bleeding gums and loosening teeth. These all lead to malocclusion. And vitamin D deficiency, here there will be disturbed classification of teeth, poor quality of teeth, narrow maxillary arch, high palatal vault, and underdeveloped mandible. Last, hypervitaminosis D. Here, Poorly calcified teeth will be present, and decalcification of bone will be present, and increased osteoclastic activity, which will interfere the tooth movement. Next factor in the general category is abnormal pressure habit and functional aberrations. Abnormal pressure habits may be in the form of thumb sucking, tongue thrusting, lip and nail biting, abnormal swallowing habits, speech defects, respiratory abnormalities, enlarged tonsils and adenoid, and psychogenic habits and bruxism. These all may lead to malocclusion. All these habits are functional aberrations which produce force that are abnormal, and these forces are capable of bringing about a permanent deformity in the developing musculoskeletal unit. And this deformity mainly depends upon three factors, that is the intensity, duration, and frequency of the habit. Next factor is the posture of the patient. If the posture is poor, it may be associated with malocclusion, but the is not that proved. Then accidents and trauma. Injury to dentoalveolar region may get unnoticed during early years of life, but it is responsible for a non-vital teeth, ankylosed teeth, and injuries at the condylar region, which often lead to malocclusions. Then we move on to the Graeber's next classification, that is the local factors. First one is anomalies in number. That may be as supernumerary too. That is the teeth extra to the normal complement, and most common being mesiodense. It may closely resemble the teeth of the group they belong, or they are no resemblance at all. Supplemental teeth are the teeth that bear close resemblance to a particular group of teeth, and they are close to the original site of these teeth. Most common being the premolar region and the lateral incisor region. These are the erupted mesiodense, and we can see in the second picture supplemental teeth in the mandibular premolar region. Supplemental teeth. Teeth bear close resemble to a particular group of teeth, and it erupt close to the original site of this teeth. Most common are the premolar region or lateral incisor region, as explained earlier. Supernumerary teeth can cause non-eruption of the adjacent teeth, delayed eruption of the adjacent teeth, and it may deflect the erupting tooth to an abnormal location, and it often lead to crowding. Another factor is missing tooth, more common condition than a supernumerary tooth. It may be of both oligodontia or anodontia. Oligodontia is the absence of many teeth, and anodontia is the absence of all teeth, which is a rare condition. And hypodontia is presence of few teeth. Example, hypohydrotic ectodermal dysplasia. This condition can often lead to spacing between teeth, aberrant swallowing patterns, abnormal axial inclination of the adjacent tooth. Then move on to the anomalies of tooth size. It may be of microdontia. True generalized form of microdontia is rare, and it is usually seen in cases of pituitary dwarfism. And most common form of localized microdontia is maxillolateral incisors, often called as peg latins. Then anomalies in tooth shape. It may be fusion, gemination, twining, concrescence, and dilatation. This often leads to spacing. And abnormal labial frenum. It's often associated with maxillary midline spacing. A heavy fibrous frenum is found attached to the interdental papilla and can prevent the two maxillary central incisors from approximating each other. This is a thick labial frenum, we can see. And it is often confirmed by a Blanch test. In Blanch test, the upper lip is pulled superiorly and anteriorly, and any blanching indicate the fibers of frenum crossing the alveolar ridge. Often an IOPA will show a notching in the interdental alveolar region also. Another factor is premature loss of deciduous teeth. It will cause decrease in the total arch length as the posterior teeth move mesially, and it will cause the ectopic eruption of the permanent teeth and often seen as midline shift. Here we can see the mesial tilting of the mandibular first permanent molars leading to decreased space for the eruption of the second premolars. Another factors leading to malocclusion is prolonged retention of deciduous teeth. Reasons for prolonged retention of teeth are absence of any underlying permanent teeth, endocrine disturbances such as hypothyroidism, ankylosing teeth, non-vital teeth that do not resolve. Prolonged retention of deciduous teeth results in the lingual or palatal eruption of their successors as seen in this picture. Delayed eruption of permanent teeth. This is another factor which leads to malocclusion. And it also often results in the ectopic eruption of permanent teeth. The reason for delayed eruption are congenital absence of the permanent teeth or presence of any supernumerary tooth. And often tooth retain because of the presence of a heavy mucosal barrier, and it can prevent the permanent tooth from emerging into the oral cavity. And any presence of any deciduous tooth fragments, endocrine disturbances, and ankylosing teeth. Another local factors of malocclusion is abnormal eruptive path. Causes are tooth bud displaced from its ideal position, presence of any supernumerary tooth and odontomas, retained tooth that may divert a tooth from its eruptive path. Retained deciduous teeth might force a tooth to erupt along a path of least resistance rather than in place of deciduous tooth. Arch length deficiency or excess of tooth material may cause one or more tooth deviate from its eruptive path, most common being maxillary canine. Here, labially erupting maxillary canine is seen. It's due to the retained 5-3 in this case or retained deciduous canine. Various reasons of this behavior are the canine travels the longest distance from near the floor of the orbit to the arch, and it is the last anterior tooth to erupt, and loss in arch length such as anterior or posterior teeth may impinge on the space required for it to erupt. And abnormal position of tooth bud is another reason for canine impaction. Another local factor of malocclusion is ankylosis. There is a union of root or part of root directly to the bone without intervening periodontal ligament. It's often associated with certain infections, endocrine disorders, and congenital diseases. Another local factor is dental caries. Proximal caries may result in reduction of arch length, loss of e-space, and migration or tilting of teeth in the space available, and supra-eruption of teeth in the opposing arch. These are the sequelae of the dental caries, which often result in malocclusion. Last one is improper dental restoration. Under controlled proximal restoration result in decrease in arch length. Over contour restoration may bulge into the space occupied by the succedaneous teeth. Overhanging or poor proximal contact may lead to periodontal breakdown. Occlusal prematurity due to over contour restoration can cause a functional shift of the mouth. These all lead to malocclusion at a later stage. Thank you.